offered a private health care plan and who opted for the savings of anywhere from $50 to $70 a month to take their child out of the private plan and enroll them in the all kids Medicaid reimbursement level health care plan. Now, it did two things. Number one, I had a very poor legislative district, 40,000 voters, 20,000 of them on food stamps. The people living in poverty who otherwise had access to care, their access dried up and went away. Today, there is not a dentist in the city of Peoria, Illinois that will take an all-kids patient. Second, it ballooned the deficit within the state of Illinois' Medicaid program, all-kids program. We are now 9 months late in our reimbursement levels. So I would just throw this out there as a case-in-point example, a microcosm in our country where we have tried a similar option, a competition, if you will, against private insurers. Second, and to that point, I don't buy the concept that the solution to greater quality, greater access, and lower costs is the government. To that point, though, I think we need to do a better job of providing, if we understand we're trying to control costs, if everyone accepts the fact that healthcare premiums rising are making it more difficult for businesses to provide health insurance, for individuals to provide health insurance, how do we lower the healthcare premium costs? Well, then we have to lower the request for services or the rates that we're paying back. My question to you would be, how do we give those tools to the consumer? Because it's my view right now as consumers, if I have a private play health care plan, whether it's provided to me as an individual or whether it's provided to me by my employer, I don't have the tools necessary. There's been a lot of competition. I'm digressing a little bit. There's been a lot of talk about health insurance being compared to automobile insurance. The biggest difference I see in automobile insurance is that if my car gets in a wreck, I'm going to do one of two things. I'm going to go around and I'm going to get probably 2 or 3 estimates, not because I'm going to pay for it out of pocket, but because I know when I turn in my automobile expenses, my automobile insurance rates are going to go up. That connection doesn't seem to be there. While it's true, but that connection doesn't seem to be in the mind of the patient as he or she accesses the healthcare system. So what tools can you in the insurance industry give to consumers? How can we look at maybe reforming the way in which people buy their health care, not the premium, but rather the actual service, how they buy it? And I understand you can't do it with emergency care, but if I go in, I live in a relatively large city, 150,000 people. A lot of places offer MRIs, and each one of those locations charges a different rate. Yet that information is not readily available to me as a consumer. And I think that is a part and parcel to us doing a better job of controlling the costs that go and drive up healthcare premiums. So if you could answer that question, I'd appreciate it. What are you doing now, and what could we be doing to give those tools better to consumers?
Gentleman's time's expired, but the witnesses can answer the question. Go ahead.
Thank you.
Congressman, I can answer that for my company, WellPoint. Several years ago, we embarked on a journey to increase the transparency so that consumers could more easily compare the prices of commonly used services within their geographic area, because you're right. There is a large disparity between an MRI in one part of the city and another part of the city, a cost for commonly knee replacements in one part of the city versus others. So we created what we call Anthem Care Compare, which is a website that identifies the top 34 elective type procedures. And a member can go into that website, type in their zip code, and it will identify different providers within the area and the costs associated that would be charged by the different facilities for those areas. Plus, we try and tie in as much quality, publicly available quality information that is available to members, so that if you're considering having your knee replaced at a certain facility, how often do they do that procedure, and what is the success rate, what are the readmission rate for that? We've rolled that out in many of our markets across the country, and actually we're now providing that service to many Blue Cross Blue Shield plans across the country. So that's one example of how we can increase the transparency.
Congressman, you mentioned MRIs, which is a great example. In some geographies, the cost of an MRI can vary by 100% or more, depending on where you go. At Cigna, we've provided the cost of MRIs on our website so individuals can go and look it up. The vast majority of the healthcare providers that work with us allow us to do that. There are some that do not allow us to show the transparency, but the vast majority do. And it does help. The other thing I would say is, along the lines of tools, that you need to provide the incentives to individuals. And I think one of the Cigna's customers is Safeway, and I think they're a marvelous example of a company that has worked with Cigna to both increase the cost and quality transparency, because it's not just cost that varies, but quality varies as well, among their employees, so that they can get the right care, get it at the most efficient price. They also incent people for appropriate behaviors, whether that's not using tobacco or exercising, because at the end of the day, for Safeway, if you have a healthier employee, it's also going to be a lower cost employee.
I thank Mr. Schock for his presence here, and if you have a follow-up questions, you want to put them in writing, we'll make sure that they go through the committee, and we support your request. Thank you. You brought up that issue. I just want to, as chair, just take the liberty of pointing out that, when you brought up the issue about car insurance and compared to health insurance, I mean, that's one of the debates right now. And just what occurs to me is that if you wreck your car, you get a new car. If you wreck your health, you're dead. Unless you believe in reincarnation. Mr. Schock, thank you.
Thank you.
Chair recognizes Mr. Cummings.
As I was sitting here listening to you all, I was saying to myself, boy, they sound real nice. I mean, it sounds like everything's rosy. And, it's amazing, the people who sat here yesterday, said some things that were very, I thought very damaging to what you all do every day. I'm not talking about you all individually, of course. And the thing I guess that I'm just sort of wondering about, and they made a big deal of this whole denial of claims. And I specifically asked them the question about whether they felt that things were worse or better since the Clintons tried to get through health care reform, and they said that they were far worse with regard to denial of claims. And so, Ms. Farrell, I'm going to go to you because I for one reason, because you had said something that interests me. You had talked a little bit early about claims that there was no one that only, I think, or maybe it was several of you said only doctors deny claims. Is that right? So you all are telling me that there are no other non-medical people who make decisions that a person cannot get a certain treatment paid for? Is that what you're telling me?
Just to clarify, what I said was that there are no medical decisions or no medical denials that are made by somebody who is not a physician. You can deny a claim for a non-medical reason, and that decision can be made, obviously, by a non-clinician.
And I take it that those kind of decisions are made every day, are they not, by non-medical people?
Non-medical decisions, yes, can be made by non-medical people, but if it's medical related, it's made by a physician.
And so a claim is for services, I just want to make sure our definitions are right again, services that are already rendered, is that right? A claim is normally for something that's already, I see you shaking your head, Mr. Bloom, is that right?
I think that we're, as a group here, struggling with what the definition of a denial of a claim is.
Okay.
To me, a claim, when I cited what the survey said about us, a claim, there are basically three kinds of claims. And the first kind has been really enunciated here quite well. That's when you get a duplicate claim.
Okay,
That's
got
when
that.
you've rendered service, as you said, and then you get a claim that comes in, and then another claim comes in, and you've probably paid the first one. In the denial rate, in the numbers I cited, the 5.7 that we have, and the 5.4 that we have, and the 8.7 that Medicare Part B has, in those claims, the biggest cause of that is duplicate claims. The next kind of claim is for experimental or investigational, where there wasn't any pre-authorization, which was also discussed earlier. Then the last kind is where the employer has not has through the policy terms decided we are not going to cover that kind of a claim, that kind of a process, that kind of a procedure. Now, the other thing that we're struggling when you are asking questions, I believe you're also talking about coverage determination,
Yes.
whether people have coverage in advance of when services are covered.
Okay, I got to ask you this. Well, I understand that a person can have their treatment pre-authorized and even get a pre-authorization number, get treatment, and still the payment for that same procedure may be denied. Is that true?
In a coverage determination, there's an initial decision made about whether this procedure is covered. And that, in our company, like in the case of Ms. Farrell's company, that's done on a denial of coverage is only, for medical reasons, is only done by a licensed board-certified medical director.
And so none of you all then, nobody up here has anyone who denies a person treatment. In other words, how many of you all deny folks, if any of you all have people who you give bonuses to or give financial incentive for denial of treatment? Nobody.
Right. I answered before, neither. None.
No. Okay. I just think that based upon the testimony that we got yesterday, the testimony was clear that there are many, many instances where insurance companies are basically intentionally, and maybe coverage, you may call it coverage, you may call it claims, whatever, holding back decisions and literally waiting for certain things to happen, and sadly, in some instances, death. The person is denied one way or the other. So he dies, as the chairman said, here, different with an automobile, the person dies. And that's a sad, sad situation.
Chair recognizes Mr. Conyers. You may proceed for 5 minutes, Mr. Conyers.
Thanks for your generosity, Chairman Kucinich. Ms. Farrell, are you aware of the report from Healthcare for American Health?
Report that you're referencing, but Aetna's profits, for every dollar we take in, we make about 5 cents in profit, pay about 84 cents in medical costs.
Well, what about you? Are you aware of this report?
I'm not aware of that report. I do know
Okay.
that if you look at Cigna's total profits globally, we make about $1.60.
I see.
I am not aware of that report either.
Okay. And Ms. Reeton, you must have heard about this.
I have not heard of it.
Somewhat deceptive
perspective in the way it's framed. There's been an enormous amount of growth among the top companies, and it's simply adding up the gross profits of companies as they've grown over time. So there is a larger share of profitability today in those top companies than there was 10 years ago. But that does not mean that profits have grown per member, per unit of business, per customer. That it doesn't, one necessarily doesn't flow from the other. It's a function
Mr.
of the size
Bloom,
of the...
you know about this, don't you?
I'm not familiar with it. Let me comment on my company.
Well, wait a minute. I don't want you to comment on your company. You're not familiar with the statement.
I'm not familiar with the second one.
In the business.
I've been at the beginning of 2001. And
Okay. Have you ever heard of Healthcare for America Now?
no, I'm not.
Okay. Well, let me ask you this question. Are you familiar with the stuff the insurance markets in the United States are?
I'm not. I would.
You're not familiar.
I'm not familiar generally with those statistics, but it's not an unfamiliar statistic that, in terms of some markets, don't have a lot of competition, but most markets have much competition. Excuse me.
Well, do you contest this a finding of the AMA?
I don't know enough to contest or affirm.
Okay. Well, let's go down the line again then. Ms. Farrell, you're a student of the, I know you subscribe to AMA journals. You've heard of it.
I am not aware of that specific
You never
study.
heard of it. Richards, you never heard of it.
No, I've not, Congressman.
Well, let me just ask it to save time. Has anybody ever heard of it? Has anybody ever heard of the AMA?
Yes. Yes.
All right. Well, let me ask you about this. Have you ever heard of the statement that's been made public, and to my knowledge never contested, that the 10 largest companies in health insurance, the CEO's compensations totaled $118.6 million, an average of $11.9 million per CEO. Now, let's save some time. Anybody ever heard of that before? Nobody. Well, you want a citation for it? Not particularly. Okay. All right. Let me ask you this, Ms. Farrell. What is your annual compensation per year?
My annual compensation is something that is very private to me, and is
Well,
something that I
wait
would
a
be happy
minute.
to submit to
You don't
the
want to tell
committee.
me. Is that what you're saying?
I'm saying that I consider my compensation to be very private,
Yeah.
and that I would be happy to submit it to the committee in writing.
But you don't want to say it publicly.
No, because I do consider it to be private.
Mr. Conyers, before you came, we asked the witnesses to submit information about their compensation in writing. If they choose not to answer at this committee meeting, but they will present it to us in writing,
Okay.
we can still get that
That's
information.
a fair agreement. Last question. Does anybody here, I've never had a hearing where 6 executives of health insurance were all in the same panel. This is a new experience for me. Do any of you want to tell me what your annual compensation is, just for the record, without having to submit it in writing?
If the witnesses care to respond, you can do that. If you don't, we certainly want you to submit that in writing.
What do you want to tell me, Ms. Reardon?
I'll tell you, I make $728,000 a year in salary.
Okay, I thank you for that. And what did you want to tell me, Mr. Bloom?
My compensation is $545,000 a year. It's a matter of public record.
Sure, and I thank you for that. And what do you want to tell me, Mr. Sassi?
I'd be
It's
happy
okay.
to provide it in writing, but it's a privacy issue.
It's what?
I consider it a privacy issue, and I'd be happy to submit it in writing.
Okay. Well,
John.
yes, I'll yield.
Yeah. Before we go to Mr. Kennedy, I just wanted understood that you've agreed to submit this information to the committee. As long as we have that agreement, that's fine. You can choose to answer the question now, or you can choose to answer it in writing. It's really your choice. And so Mr. Conyers, Mr. Kennedy.
Yeah. No, I just, to yield, just to be happy, John was bringing up a point. I think the folks here are just obviously just working as in a field that's perfectly legal and set up by our society to earn what they're doing, and nothing wrong with that. I think what is wrong, as the gentleman's trying to point out, is that last year the head of Cigna earned $11 million. Now, if you're going to talk about where that money's coming from, it's clearly coming from denied claims. The head of the United Health Group earned $9.4 million. Now, these are public records, so you don't have to ask anybody here. They're nice to, I'm sure they love to be called senior executives, but frankly, John, I think they hope to be senior executives at those kinds of pay scales, but I'm sure not at that level yet. But the point is, we're trying to make the point that the industry is allowing for these kinds of exorbitant pay at the very top, which just beg the question. It's an allowable industry in our country, but we need to know, kind of what is this a matter of where these dollars are coming from when people are paying these premiums and people are getting rejected for health care. How are these compensations so exorbitant? So I appreciate the questions you're asking. I also understand the fact that these individuals here have every right to say and do what they're doing, because
Mr. Kennedy,
they're just working in an industry.
If I may, Mr. Kennedy, Mr. Conyers' time has expired. Yeah. However, we will now go to you, Mr. Kennedy, if you want to yield any time back to Mr. Conyers. You can proceed for 5 minutes, and we're going to go one more round after that, and then we'll be done.
Okay.
Because I know everyone here is trying to.
Well, I'd like to, Mr. Chairman, go back to this whole idea of how we're, if insurance has thus far not gotten around to figuring out ways to help the government or the society change reimbursement reform. If we've known for years that our system is upside down, that all we do is pay for sick care rather than health care, if there are simple ways for us to keep people from being frequent flyers in our emergency rooms, if we just did X, Y, and Z, and that would lessen the pressure on you as insurers to charge your customers exorbitant premiums, then why haven't you in your industry taken upon yourself to be the biggest advocates for insurance reform over the last 20 years? And furthermore, what I don't get is that back home, like most of my businesses, are for the most part are passive when it comes to their insurance premiums. They let their insurance carriers kind of dictate to them. They said, oh, well, here's your premium this year. And in fact, it's the insurance companies that work for the company that they are subscribing for. And they've been hired to do their policies for. And so I just don't, for the life of me, understand why, if it's in the interest of their client to reduce premium costs and so forth and health, why insurers in this country haven't been at the forefront of this healthcare debate, saying, listen, here are the ways we can restructure the healthcare market based upon a capitalist system whereby it pays to have better care at reduced costs. That's what I can't figure out, Mr. Chairman. If this is really about making money, we know there's plenty to be made. Why can't they build a better mousetrap to make money and also save money? And give us the answers. You think is consistent? I have to sit up here and ask about things that I frankly am not all that educated about, because my staff person puts it in front of me and they're going to promise to get back to me on, value-based streamlining in engineering. Can that apply to healthcare? All of these kinds of things that we're going to have to try to put in laws so as to enforce insurance companies to bring their costs down. Why do we have to put that into law? I'm sure they don't want to be regulated any more than they are being regulated. So tell us why, because we're being pressured to bring our deficit down. We've got this enormous deficit. It's going to swallow up all our future dollars, taxpayer dollars. Our taxpayers are going crazy because they're getting on our tail for having a big deficit. And what we're trying to do is respond to them and say healthcare is one of the biggest financial nuts our country has going forward. So we're asking you, help us, because one way or the other, money's going to have to be streamlined, and it's a question of whether it's going to be done at the expense of our consumers, which we don't want, or it's going to be done efficiently and with quality in mind so that people don't get their health care cut just because we haven't been on the forefront of making the right decisions policy-wise that allows them to continue their health care in the most efficient way possible. Maybe you could comment on why you don't think you guys have been in the head of the game in terms of getting better reimbursement reform prior to this year. Why does the government have to do all this incentivizing for health rather than sick care? Why are we the ones who have to do this? Why haven't you been out there for years doing this stuff?
Congressman, I'd love to respond to your question. First of all, I think there are some things that we can do individually. Certainly at Cigna we do several things to improve the health of our customers. For instance, we have a gaps in care program where we monitor for evidence-based care to identify if our customers aren't getting the care they need. For instance, somebody who has recently had a heart attack who's not on the proper medication of beta blocker. By mining that data, we can then outreach to that individual's doctor and to the individual and say, shouldn't this person be on a beta blocker? Because medical evidence would say that for most people that's appropriate, and if they don't take that drug, they're much more likely to have another heart attack. So that's an instance where we are using technology in our people to actually increase pharmaceutical claims for the better health of the individual. That's something we can do and do alone today. Relative to your payment reform question, again, Cigna is working with a variety of healthcare professionals. I referenced Dartmouth-Hitchcock in New Hampshire. We're actually working with 5 other entities around the country for payment reform, where we have a patient-centered medical home where a primary care doctor can coordinate the care, because it is a complex system. If somebody's very sick, they tend to need a lot of different doctors, and having that primary care person look after the care is very important. A lot of primary care doctors can't afford to do that today because the reimbursement rates that Medicare and private insurers pay them, it's very tough for them to be able to do that. So the medical home is a promising pilot that we're trying, where we are paying extra money to those primary care physicians to allow them the time to help coordinate the care. So I think there are things that we can do individually. There are things we can do in partnership with healthcare professionals, the doctors and hospitals, and then I think there are things that the government needs to help on as well. And Cigna and the industry have definitely supported reforms for a variety of things that we've mentioned at the committee today, where we really need government to work with us to help enact some reform as well. And we look forward to working with you in this debate, Congressman Kennedy.
My point is that medical home, we've known for a long time, works. Why are we piloting it? I know it's what we're piloting in the legislation, but we're only doing it because we're slow walking something that we know works. It's been demonstrated over and over again. I mean, it makes so much common sense. It's like this whole trigger thing. We're doing what is inevitable, but we're going to take us extra 4 or 5 years before we take the whole medical home thing to scale, because we're just, there's too many financial interests that we're going to have to tiptoe around in order to get this thing implemented. But if you guys stood up and said, hey, we all know medical homes are about making more efficient, giving the primary care doc and gatekeeper more time to help coordinate care, because 80% of the dollars spent on 20% of the people, they're the chronic users, they're the highest paid users of health care. That's where we get the most money. Let's do it. Boom. Let's go. What are we slowing down for? The reason we're slowing down is because there's this inertia out there because everybody's trying to protect their piece of the turf, and we wouldn't have that if insurance was more proactive. It's in your interest to be more proactive because at the end of the day, we're going to hit the wall. And when we hit the wall, you know, everyone else who's well off is going to be fine. It's the people in the middle and the bottom are going to be the ones that get hurt.
You know, the gentleman's time expired quite a while ago, but I'll tell you, I think everyone in this room and everyone watching knows how important what you just said is, and we're wondering if there's any response to does the industry care to respond to what Mr. Kennedy said? In a way, what he's providing is a wake-up call here. Does anyone here care to respond? We're gonna have one more, Mr. Kennedy. We're gonna have one more round after this, and then we'll wrap it up. Anyone want to respond to Mr. Kennedy?
Mr. Chairman Kucinich, we've submitted and will submit for the record proposals that we circulated with the administration in Capitol Hill of $500 billion of potential savings. I won't.
Over what period of time?
Over a period of time from 2010 to 2019. And we'll submit this report to the committee as part of the record.
How much was that again?
It was $540 billion, sir.
Okay, that would be helpful, and anyone who wants to submit similar information, so ordered, and we appreciate you doing that. I just want to say that as we go to the final round of questions here, I'm sure that the insurance company executives who are here recognize that everything's changed with respect to health care in America. You're facing a totally new environment than when you started your careers in health care. 47 million people uninsured, another 50 million underinsured. As you know, many people are losing everything they have because they can't afford to pay their hospital bills. And many of those people had insurance. And so today we're talking about this business model. But we also have to understand, I mean, we have great respect for you being here, but we also have a great understanding of your position and your political power. Let me give you an example. The insurance companies are so powerful that you were able to take H.R. 676, Medicare for All, right off the table, right at the beginning of the discussion, for either party, just about one party or another. Both parties took it off the table. There's 85 members of Congress who have signed on to it. It's a bill that Mr. Conyers and I drafted. 86, thank you. But the point is that you were able to exert your influence, and you gave some of the reasons here today. I mean, very clearly it clashes with your business model. We understand that you're very influential here. Based on your influence, we're seeing the so-called public option, which would provide some competition. We understand you feel that it wouldn't be productive. But based on your influence, the public option looks like it's going to be very difficult to get into a final bill. And of course, the industry has had an influence in shaping issues such as triggers and co-ops. What Mr. Kennedy had to say, that I think is so important, and where Mr. Kennedy's comments lead to, is that you should be thinking about the fact that the business model that you have could end up being, could end up killing the goose that laid your golden egg. You may be reaching an end point as to how much medical loss ratio you can go before people start to say, what's going on here? How far can your executives go making millions of dollars a year while people's claims are being denied, you might say there's no connection, but the public does make a connection. And look at where we're headed towards. This is where your presence here is not a small matter. We could very well be headed towards a condition where healthcare reform in America is really more of a continuation of what I call insurance care, whereby the 30 million people, according to the CBO, would be potentially covered by H.R. 3200. Without a public option, 30 million people would be pushed into private plans. They have to choose among private plans, and if they don't do that, and they don't choose and they don't pay, they can be penalized. It's extraordinary. But with that kind of power, I would hope you start to think about a different model of business's social responsibility. I'm not lecturing you here. I'm just sharing some thoughts. The insurance industry, because of changes in the global climate, is due to take enormous hits, particularly in coastal areas, over the next 40 years. There are areas we should be working together. But on health care, you may eventually want to think about what it's going to be like when you wind down your health care products. Because frankly, Mr. Chairman, I think sooner or later, whether it's this decade or another decade, you're moving towards a condition where more people are going to be uninsured, more people will be underinsured, premiums, copays, and deductibles are going to be out of the reach of more and more Americans, and they're going to put it on you. And you know that. And so, you know, I didn't call you in front of this committee today to embarrass you. That's not my intention at all. We need to get information about how your business model works, because people really need to understand that. We understand you're not charitable organizations. That's not why you were formed. You're responsible to shareholders. We understand that. If your medical loss ratio changes too significantly, Wall Street will punish you. We understand that too. The question is this business model sufficient to provide health care for the American people at a cost that's affordable? There's a collision here. And you happen to be at that time and place where this collision is happening. I'm going to ask one final question as I wrap up my time here. Yesterday, we received testimony from Aaron Ackley of Montana. Aaron's father, William Ackley, and his obituary is part of the record, had a request for a bone marrow transplant. And that request was denied coverage on 4 separate occasions, causing a delay of 126 days in his cancer treatment. He ended up dying from the cancer. Now, Aaron Ackley told this committee that he had been enrolled in Medicare, that had he been enrolled in Medicare, he would have received his bone marrow transplant right away. And government-run Medicare provides primary health insurance to most senior citizens, has developed standardized forms, standardized benefits. Its administrative costs, as you know, are a fraction of yours as a percentage of revenues. Now, I'd just like to go down the line and answer this question. Isn't it true that your reason for not adopting Medicare's coverage standards as your own is that you could not deny payment for expensive treatments such as the one I just referred to? Mr. Collins.
Chairman Kucinich, I can't answer that question. I'm not familiar with the Medicare guidelines. That would have been something appropriate for our Chief Medical Officer to discuss.
Yeah, like Mr. Collins, I am not familiar with that.
Okay, Ms. Farrell.
The same, unfortunately, I'm not familiar either.
Mr. Blum.
Or myself.
Mr. Richards, can you answer that?
No, our Chief Medical Officer actually used to be the Chief Medical Officer for CMS, Dr. Jeffrey Kahn.
Thank you.
Had he been here today, I'm sure he could have answered it.
Thank you, but I'm glad that you're here because I got a chance to ask you about your town hall meetings, and I'm really interested in that. So thanks for being here, Mr. Richards. Ms. Reed.
I've got the same problem that everyone else mentioned. One of our chief medical officers could have answered that question.
See, I mean, you know where you may not be as familiar with the Medicare standards, and I'll accept that answer. But I think you understand why I asked the question, and that is we're trying to get to the genesis of the business model here. How do you make money? Now, many Americans believe that insurance companies make money not providing health care, that your first obligation is to the stockholders, the shareholders, and then you have an obligation somewhere down the road to the people who are your policyholders. You have to have some obligation. You do pay. You said you have. You have a pretty good batting average in a lot of that. But when you get into the mechanics of analyzing it, to raise some questions, which is what we did here today. Mr. Conyers, do you have 5 more minutes for questions, or do you wish to?
I'm so nearly exhausted, Mr. Chairman. I hardly have anything else to say, but to thank you for this meeting and to thank our witnesses for holding up. But, you know, it's been made public that the American Medical Association has sort of come out for the Obama approach. You all have heard about that, have you? No. Yes, no. Okay. You don't know if the AMA is with Obama or not. What about your companies? Have your companies said anything one way or the other about Obama's strategy of health reform? Anybody? You don't know? Yes, sir.
Congressman Cigna has come out, as have many others in the industry, and supported many aspects of the President's plan.
Oh, okay. Well, let me put it more delicately. There are parts of the Obama H.R. 3200 approach that that your company is for, and there are other parts you may not be in full accord with. Is that about fair enough? That everybody shakes their head. There are parts you can go along with, and some parts. Obviously, public option is not one of your favorite parts of the bill, wherever it may appear. But there may be some other things. But there are things you like.
Congressman, I'd say there are many things we like, yes.
Pardon?
There are many things we like, yes.
Many things you like, yeah. Well, thank you. Let me just ask you about the Baucus bill. Now, you got a reaction. Did he make a little impression on you, or somewhat favorable? How does that resonate with your company?
Congressman, just from Cigna's standpoint, I know that Senator Baucus just came out with it, and we are still reviewing the details of that bill.
Yeah, but so am I. I mean, we all got the news at the same time. It's been on television, newspapers, commentators, doctors. Come on. I mean, how long do you have to,
Congressman,
how much study do you?
From my understanding, there's no legislative language, actually, that's been shared yet. But again, we are studying at least what has been released.
Really?
That's my understanding, yes.
But he's been preaching about his bill and copying headlines all over the place. You say there's been nothing specific. There's a bill out. It's got the chairman of the Finance Committee of the Senate. Well, I'll tell you what. Could you, I know you've got a lot of assignments coming here today. Could you let me know when your companies have examined it sufficiently to let me know what you think of it? Okay, all right, thank you very much. Now, finally, we had testimony in the Judiciary Committee under Subcommittee Chairwoman Linda Sanchez from doctors that there were 1 million medical bankruptcies in the United States. That is, personal bankruptcies caused by medical bills. Ever heard of that? Nobody's heard of that. Okay. Well, I can't ask you to comment on that. Let's do it hypothetically. If you heard and learned about that, would that cast some concern on you about the problems that individuals are going through when the largest cause of individual bankruptcies in the United States are due to medical bills that people couldn't afford? You'd be concerned. Well, may I send you some things? You're sending us a lot of things. Can I send you some more information about that subject? Okay. Thank you, Mr. Chairman, for your generosity.
Well, I thank the gentleman. Finally, Congressman Kennedy, you may proceed for 5 minutes.
Thank you, Mr. Chairman. Thank you for holding this hearing, Mr. Chairman. Appreciate it. Thank you all for your patience this afternoon, hearing our questions, and looking forward to getting responses to the ones that I asked earlier. I would ask all of you if you would just give me an affirmative in terms of working with my office in closing a loophole that appeared in last year's Wellstone-Domenici Mental Health Parity and Addiction Equity Act bill. We applied it to all insurers for mental health benefits. It seems as though college students' health insurance plans do not have the it's not applicable to college students' health care plans because students are not technically employees of the university. So the bill talks about this as covering employee-based health insurance plans. So you see the wrinkle there, and as a result, since students aren't considered employees, they're not subject to the requirement. The insurance companies who insure students aren't subject to the requirement for parity. And because suicide amongst kids is the third largest cause of death, I would ask all of you now, would you be willing to work with me to close that loophole in this health bill with language that ensures that the spirit of the law that's applying to all of you for every other health insurance plan ensures that kids who need it the most, if you will, get that coverage as mandated under the Wellstone-Domenici parity bill.
Yes, Cigna actually strongly supported the Domenici-Kennedy bill, and we'd be happy to work with you to close the loophole.
That would be great. Okay, if you could, William Gardner in my office, and if you could be in touch with him, we're just trying to make sure we get that facilitated in this bill so that the kids don't get, disrupted in their health insurance coverage. Obviously, I have a lot of other things, but just want to make sure we tidied that up. Thank you, Mr. Chairman.
Thank you very much, Mr. Kennedy and Mr. Conyers, for remaining. This has been a hearing of the Domestic Policy Subcommittee of the Oversight and Government Reform Committee. We have gone over 3 hours now, and the witnesses have been much appreciated in your presence here. The title of today's hearing, Between You and Your Doctor, the Private Health Insurance Bureaucracy. I feel, as Mr. Kennedy just implied, that we've barely scratched the surface here. But I hope that the witnesses understand, and hope that you feel that this committee has treated you fairly. There's no browbeating here. There's no trick questions. There's no attempt to try to force you to give an answer over something that you're not ready to do at this moment. And that's the way we're going to continue to proceed. We are a fact-finding, investigative subcommittee. We're going to continue to try to get information from the industry so that we can understand your business model a little bit better. And while I try to conduct these hearings in an impartial way, away from these hearings. I'm a very strong advocate of the bill that I wrote with John Conyers. But I don't let that interfere with the conduct of this meeting. I want to make sure that you're given a chance to put your point of view on the record. And so while you're treated fairly here, we're hopeful that you're going to treat the American people fairly. And I think as we move forward, this issue of awareness, Mr. Conyers is going to send you some information. I think this is a time that we can become more aware of your business model, and maybe you can become more aware of why we have such great concerns and why there's a national movement right now to really move away from the model that you've spent your life building. So it's a great time for this debate in the country. Healthcare ends up being a flashpoint. You know this. People losing their jobs, their homes, their retirement security, their investments. And you're right at the point where it's a flashpoint. So let's see if there is a way that we can find to best serve the American people. That's why we're in Congress, and I hope that's what you'll conclude is a good purpose to be in business. I'm Congressman Dennis Kucinich, Chairman of the Subcommittee. This committee stands adjourned.